We're Sentia Health. We're in the business of streamlining and automating processes and have even automated the production of new software. Today, we are going to talk about the state of health insurance in the US. In 2016, I read an article by Shane Snow titled Trickle-Down Healthcare: How We Could Actually Fix the US Health System. His basic assertion is, nobody is minding the store. Nobody really knows or cares what healthcare costs because they aren't paying. He further states that, on average, only 53% of your health insurance premiums get returned to you as benefits. Yes, I know that the Affordable Care Act of 2010 mandated that health insurance companies can only keep a maximum of 20% of your premium and has to return the other 80% as benefits. However, the ACA states, an insurance company must assign 80% of their premiums to activities that develop the healthcare sector. Developing the healthcare sector doesn't sound like paying for your colonoscopy to me. Further, if you go looking for this information today, Google and Bing tell you about this mandated 80%, not what the actual premium to benefit ratio is today. Originally, this information came from the Insurance Information Institute. Not only can I not find this on their site any longer, I reached out to them and they proclaimed they don't provide this information. What do we do about this? If we accept Shane's assertion that nobody is watchful of rising medical costs and his statement that 47% of your health insurance dollar is wasted, what is the solution? Let's enumerate the actual functions of an insurance company. Basically, insurance is a bank that only pays certain people. You can't use health insurance to buy a car or a house, but they will pay for your colonoscopy. Sure, there are rules about what procedures get paid for and who can have some procedures, but generally, it seems like insurance could be replaced with a high school kid with a PayPal account. I suggest that the society has the means to automate this entire process. If the insurance company provides the electronic medical record system, EMR, the practitioner uses to document patient encounters, then they know what procedures are performed. Then they can pay for procedures performed in real time, short-circuiting the entire coding and adjudication process. You don't need big buildings, chairs, desks, PCs, and most importantly, people gumming up the process. All that is expensive and time-consuming. Once again, for the people in the cheap seats, we can automate health insurance and cut out 47% of the associated costs. How does this new company make its money, though? Just like Netflix, it is a subscription service. You charge the patient the actual cost of the risk, plus a finance fee to break the yearly premium into month-sized chunks, plus a data management fee of, say, $10 per month. That leaves 40+% in savings. Why would doctors go along with this? Don't you have to have networks and contracts with negotiated rates and attorneys and all that stuff? There goes your savings, right? Not so much. Instead of all that monkey motion that the patient, you, pays for, this new company could offer 125% of the Medical Consumer Price Index, MCPI, for any given procedure. The practitioners would jump at the opportunity for a raise without having to sit in a boardroom with a bunch of attorneys wondering not if they are getting screwed, but how hard. What about regulatory hurdles, you ask? I talked to Lena Cook-Rush of Baker Donelson's insurance regulatory practice, and she stated that outside of the reserve fund mandated by the state, there should be no regulatory hurdles at this time. What about that regulatory reserve money, though? A large existing insurance company should have no difficulty in coming up with the regulatory reserve amount. They already have it. A new, smaller company can take out a line of credit with a lender. When the new, small insurance company sells a policy, they can pull the regulatory money from the line of credit. That is where the finance fee came from earlier. An EMR is really hard to write, you say? Yes, it is. Most of the reasoning behind that is that the doctors think they need a bespoke program for their specialty, and legacy insurance companies mandate doctors speak International Classification of Diseases, ICD, currently in version 10 or ICD-10, and Current Procedural Terminology, CPT. These two code sets are not adequate to document a patient encounter. That is where the smart people at CAP and NHS come in. They came up with a nomenclature suitable for documenting the entire patient encounter. This nomenclature includes well over 350,000 concepts. Even better, the National Institutes of Health, NIH, combined SNOMED CT RX norm, the National Drug Database, and the Value Set Authority Center, VSAC, into the Unified Medical Language System, UMLS, that not only combines these three, but translates them into a self-referencing and self-documenting schema, where the same programmatic techniques can access any of a large number of medical nomenclatures. The UMLS has over 14 million concepts. That means we can translate back and forth from ICD and CPT to deal with those pesky, inefficient, I'd go so far as to say evil legacy insurance companies. Combine that with some fairly standard status monitoring, like heart rate, blood pressure, etc., and something detailing the appointment place and time, and there is your EMR. I can hear you thinking, certainly there is more to it than that. Well, sure. We talked about the rules engine earlier. There are any number of rules engines suitable for typing your rules into. Personally, I use Microsoft's NuGet Package Rules engine. There are several other features that should be considered. First, a patient portal. We need something suitable to allow a doctor to see your medical records. Maybe you broke your leg skiing in Switzerland and your doctor needs your records. A secure email viewer. You can't email personally identifiable medical data. An SMS text messaging system. This allows us to inform patients of changes in their records or patient financial responsibility. A medical procedure cost estimator. Nobody provides a comprehensive cost estimation tool. Epic gives you the amount paid for a single procedure and your deductible, but does not include any additional facility fee, staff, materiel, or anesthesia. A medical imaging system. Everyone needs to see X-rays and MRIs and be able to share them appropriately instead of retaking them. This includes drawing on the image to direct attention to a problem or interesting spot on your scan to a remote viewer across the internet. Telemedicine. It is crucial to have the ability to consult with a patient or another practitioner without Zoom, or even leaving the EMR while viewing the above-mentioned X-ray or MRI. Health and wellness. Preventing disease in the first place is paramount to getting this up and running. Show the patient what is abnormal, by how much, and what to do to fix it. We can put some teeth in the system by recalculating rates for having better, or at least not worse blood work year over year, indicating you are following recommendations and therefore earning a discount. Everyone's costs will go down. Configurable questionnaires. Nobody wants to sit in a waiting room with sick people with a ream of paper and a pen filling out name, address, and phone on every sheet. Give the practice the ability to compose, configure, and publish surveys that can be taken at home or on a tablet at the office. E-prescriptions. We need to track prescriptions in one place, with the medical records, to be able to calculate the efficacy and distribution of drugs. Packages and bundles. An appendectomy isn't just removing the appendix. Anesthesia, pre- and post-care, sutures, drains, and all the other things will be included and accounted for with a package. Frequently, an upper and lower endoscopy are done together to save costs. This savings can be passed on to the patient in a bundle. Research. Since we are using SNOMED, we have structured data for symptoms associated not only with procedures, but with outcomes as well. This gives us the ability to find out what correct diagnoses are associated with which symptoms. That is a first in the world. It also makes Dr. House look a little silly. He could just ask the EMR. Online scheduling. Everyone will have the ability to schedule a visit with their practitioner in the next available spot and slot. Security and privacy. We have a required practice of passing a globally unique identifier with every database call to identify the user and his or her valid, authenticated session. This is also the basis for our authorization, or who can see what, and a purpose-built auditing system that details what any user saw, when they saw it, what change they made, if any, and what the old data was. This also is unique in the industry. Since these are all solvable problems, now I can hear you thinking, what are we waiting for? Well, there are several hurdles. A team suitable to bring home the project. Members have to be conversant with a number of fields, including medicine and programming, and be able to look past what is and see what should be. Tall order. Luckily, we have put together just such a team and made them almost foolproof with the collaborative design process and a code generation tool that writes over 50% of the code and all of the structure. Resistance to change. Nobody wants to upset the apple cart and change the entire way they do business. I say, look at the benefits. The practitioner gets an immediate 2,500 basis point increase in revenue. The consumer gets about a 4,000 basis point drop in cost. They get a free EMR and all the benefits mentioned. Getting the word out. We wouldn't want to sell a bunch of policies only to fail at the practice's reception with, "We don't take that insurance." This could probably be solved with a big advertising campaign. Alternatively, we are posting to many different health IT sites, publishing a newsletter, and even making videos. Slim margins require near immediate adoption. Luckily, with a 40% plus savings, instant adoption should be easy. The market penetration should be high and fast. At $10 per month, it has to be. On the other hand, if this takes off the way we know it will, there are 300 million insured people in the US alone, and at $10 each, that adds up to $36 billion per year. Worldwide, that is getting close to $1 trillion per year. My research with Mrs. Rush at Baker Donaldson shows that it costs about $1 million buckaroonies per state to be licensed to sell health insurance. However, with a couple or few successful deployments, we should be able to bypass a lot of that on subsequent installations. Fraud. Anyone with an MPI number can sign up for payments. We assume that doctors with a lot to lose won't commit fraud. We operate under the assumption of trust but verify. Moreover, it is far more cost-effective to let a small charge slip than to adjudicate every claim like the big, evil insurance companies. Finally, we have a data science department to weed out fraudulent payments. The FBI is also tasked with combating fraud, so they can do the investigation. The real answer to what are we waiting for is the will of this society. Luckily, we have a few other things going for us. The ACA, Obamacare, has a site to publish these new policies on. A little bit of actuarial calculations to assign procedure payments and premium costs, and a few keystrokes, and you are published to healthcare.gov. Practices will no longer need medical coders. Practices will no longer need to pay for an EMR. Practices will gain 25% on payments for procedures overnight. 40+% reduction in cost for the patient. No insurance networks, no lawyers, no negotiations, no contracts. Just a 25% payment increase with the knowledge of take it or leave it. At those rates, every practitioner will take it. In conclusion, I have shown a way to save at least 40% over the cost of legacy health insurance. There are all kinds of ancillary consequences too. If you, as an employee, go to your HR department and find out the total cost you are paying for your health insurance, spoiler alert, it is probably close to $1,000 per month, including what your employer pays, you could drop that policy and get a $1,000 per month raise and buy your own insurance. For under $600 per month, you could sign with us and give yourself an automatic $400 per month raise. That's a nice used BMW or amortized college tuition for your kids. It wouldn't cost your employer a dime either. There you have it. A complete plan to save 300 million insured people in the US hundreds of dollars per month each, complete with an analysis of risks, benefits, and a complete execution plan. No reason why this won't work for billions around the world too. I can't see why we wouldn't do this. Don't let anyone convince you that it can't be done either. As an aside, my dear old mother got a letter from her health insurance company last week stating that they could not come to terms on a new contract with her practitioner, hospital, or provider. She lives in a small North Texas town, and there aren't a lot of choices to begin with. Probably what will happen is that this 79-year-old woman is going to have to get in her car and drive to the nearest large city, an hour away, to get her medical care. There is still a perfectly good medical city 5 minutes away from her home, but she can't go there and have her care covered. This is the evil of having finance put their greedy, inefficient, nasty little fingers in our healthcare system. What do you think? Tell me in the comments why you think this is the best idea since sliced bread, or why you think my head is full of rocks. I will read all of your comments and respond to most. Who knows? Maybe you can teach me something.